Tori is a certified dementia practitioner and the Dementia Care Specialist Program Manager with the South Carolina Department of Aging. After 20 years of leadership experience in the private business sector, Tori made the career change into dementia support after having been a caregiver for her father, mother, mother-in-law, and brother, all of whom were diagnosed with Alzheimer's disease or another form of dementia. Helping families navigate a dementia diagnosis and empowering the residents of South Carolina to do the same is her life's passion. We welcome the opportunity to benefit from her knowledge and experience. Thank you, Tori.
Thank you, Carrie. Hi, everybody. I'm Tori Anderson. As Carrie said, I am a certified dementia practitioner and the Dementia Care Specialist Program Manager for the South Carolina Department on Aging. And I'm going to be presenting a program today called Dementia 201 Positive Interactions. And that really focuses more on kind of a basis of dementia and what it might be like to experience that, but more importantly, maybe some strategies for effective communication and problem solving when supporting a person who's living with dementia. But we'll also talk about that intersection between a person who is living with an intellectual or developmental disability and dementia, and how that might kind of impact how we interact with that person. So our learning objectives today are to develop a foundational understanding of dementia, identify the intersection of IDD and dementia, understand what it might be like for that person experiencing dementia, and learning some practical communication and problem-solving strategies to effectively support those living with dementia and IDD. So it is really important for us to have a good foundation of what dementia is and is not before moving forward with the practical portion of our class today. So what is dementia and what is the difference between dementia and Alzheimer's disease? That is one of the most common questions that I get. And truthfully, people in our own industry, we're not very good at using language that helps people differentiate between the two. So I like to start with that. So dementia itself is actually not a disease. It's a general term that's used to describe symptoms like a lack of memory, a loss of judgment, behavioral changes, or other thinking abilities that are severe enough to impact a person's day-to-day life. Alzheimer's disease is one of many degenerative brain diseases that cause those symptoms of dementia. So as you see in the illustration on the left of your screen, dementia is kind of those symptoms which form an umbrella. And underneath that umbrella are the different diseases that cause those symptoms. Globally, there have actually been well over 100 different types of dementia identified, which is kind of mind-boggling, right? But the most common ones that we tend to interact with here in the state of South Carolina, in addition to Alzheimer's disease, are vascular dementia, Lewy body dementia, frontotemporal dementia, and oftentimes somebody can be diagnosed with more than one type of dementia. So this is kind of a quick chart that helps better understand particularly some of the early signs and symptoms and how they can really be very different between the different causes of dementia. So Alzheimer's disease tends to have common early symptoms of short-term memory loss, difficulty learning new information, challenges with executive functioning like planning and problem solving. Dementia with Lewy bodies tends to be different. Visual hallucinations, significant fluctuations in cognition from day to day or even hour to hour, and REM sleep disorder, which involves acting out dreams in the night. Those tend to be common early symptoms of dementia with Lewy bodies. Frontotemporal dementia, there really are two general types, behavioral variant, which tends to demonstrate changes in behavior and personality. So things like lack of impulse control, compulsive behaviors, lack of empathy, not being aware of how to behave appropriately in a social setting tend to be some of the common early symptoms. And then the other is primary progressive aphasia, which tends to impact a person's ability to produce and comprehend language. And then vascular dementia, which is caused by things like stroke that can reduce or block blood flow to certain parts of the brain. Exactly what that manifests like in a person's changes really will depend on the part of the brain that is impacted by that. But that's just kind of a quick crash course and a good illustration of why it's really important to, as much as possible, try to determine the type of dementia that a person may be diagnosed with. So dementia symptoms typically include changes in at least one, typically two or more of these cognitive areas. So complex attention, that's our ability to control, shift, and divide our attention and focus. Executive function, again, that's in our frontal lobes that helps us plan, problem solve, regulate our emotions, and critically think. Learning and memory, right? Taking in, storing, and being able to retrieve information when we need it. The formation and comprehension of language. Now, these last two tend to be less well known by the general public. Perceptual motor. And that's how we respond to our environment by combining the use of our senses and our motor skills. And then social cognition, which is our ability to manage emotions and exhibit behaviors that are appropriate to a social setting. Something that's really important for everybody to understand before you leave here today is that no form of dementia is at all a normal part of aging. Yes, our risk for dementia increases as we age. In fact, advancing age is the #1 risk factor for dementia. However, our risk for lots of things will increase as we age, things like cancer, heart disease, etc. But it doesn't mean that we are inevitably going to be diagnosed with any one of those. It's not just part of aging, it's the result of a degenerative brain disease. So because Alzheimer's disease is the most common cause of dementia, we're going to take just a moment to talk through what Alzheimer's disease is. So if we were to jump into a healthy brain and be able to look close up, we would see something like this image that you see on the left-hand side of your screen, right? So here we see nerve cells that are communicating with one another by sending electrical and chemical messages. In Alzheimer's disease, abnormal sticky protein clusters called plaques form and cause a buildup between nerve cells, preventing that communication between them. Another protein within the nerve cells collapses into strands called tangles, which prevent the transport of nutrients and other essential substances within the cells. So as those plaques and tangles spread throughout the brain, it causes those nerve cells to die and that brain to shrink. So this progression goes through 3 general stages. Now, sometimes in a clinical setting, you'll hear 7 stages. That's the global deterioration scale. In our social services arena, we generally speak about Alzheimer's progression in 3 general stages. And I do want to stress that this is specifically for Alzheimer's disease and does not necessarily represent the progression of other forms of dementia. So the first is the earlier mild stage, and this stage typically begins in the temporal lobe, highlighted here in blue. The hippocampus is what is located there, and among other things, what primarily happens in this area is the formation of new memories and language comprehension. And that's why the first symptoms of Alzheimer's disease do tend to involve forgetfulness, especially with recently learned information, as well as challenges with language. So a person in the early stages of Alzheimer's disease may have challenges remembering recently learned information. They may repeat questions or statements, struggle to engage in and follow a conversation, become easily overwhelmed, especially in social or chaotic situations, and may have difficulties remembering to perform daily tasks as a result. So important at this stage is routine, structure, and engagement. It's important for us to remember that the list of things that a person in the early stage of any form of dementia, what they can do, is much longer than the list of things that they have challenges doing. So it's important for us to listen to their needs, support their independence, and encourage that engagement. As Alzheimer's disease progresses to the moderate stage, we tend to find increasingly poor judgment and confusion with time and place, so there does tend to be a greater tendency to wander. There may be difficulty remembering personal information like home address and phone number that person would not have had trouble remembering a few years ago. There will likely be progressive communication challenges, and we'll discuss those in the next few minutes. The person may become moody or withdrawn. They may show apathy, a lack of interest in typical programs or activities that they would have really been excited about doing. They may have some personality and behavioral changes, things like restlessness, agitation, suspicion, and repetitive behaviors like finger tapping or doing and undoing a task repeatedly. There will be more assistance needed for a person in this moderate stage of Alzheimer's disease, but again, there are still many things that this person can do, and we want to make sure that we focus on that. In the final stage of Alzheimer's disease, there is significant damage to the brain, as you see here in the illustration. Individuals eventually lose the ability to respond to their environment, to communicate with words, and will ultimately lose physical abilities like walking and swallowing. They may still say words or phrases, but communicating needs becomes difficult. Less interest in or ability to eat can lead to weight loss, and they may sleep much more often. As the brain continues to degenerate, individuals need extensive care with nearly all activities of daily living, such as dressing, eating, and toileting. Providing comfort and reassurance is the number one thing we can do in this stage of Alzheimer's disease. So when we look at a comparison between a healthy brain, which you see on the left, and one with severe Alzheimer's disease, which we see here on the right, you can see that there's a significant difference, right? This is a degenerative brain disease that causes changes in that person's abilities and personality that they are not able to control. Things like comprehending their surroundings, communicating their needs, following directions, and behaving appropriately. I want you to keep this image in mind. Sometimes I make the analogy of if you were to walk in and you saw that I was sitting with a cast on my leg, you might not know all the details, but you would have enough of a visual cue to understand maybe what some of my limitations might be. I might not be the first person you ask to go run an errand for you, for example. But somebody with a degenerative brain disease, and oftentimes this can be the case with somebody who is living with a developmental disability, it's not something that is a visual cue, right? With dementia, we need to understand what is happening inside that person's brain and how that's connecting to what's happening on the outside. So let this image that you see on your screen be your visual cue when interacting with somebody who's living with dementia. So let's talk a little bit about prevalence of dementia in the IDD space. And I do want to make sure that I'm giving a clear disclaimer and setting expectations that I am a dementia specialist. I do not work in the IDD field, but I do a lot of research and have collaborated with a number of people in the IDD field. So I do feel like it's really important for us to kind of talk a little bit about that intersection and make sure that we are addressing that here today. So the prevalence of dementia is sharply rising in the space of IDD. Can anybody maybe hazard a guess as to why? And you're welcome to put your answer in the chat. You're welcome to unmute your mic. Anybody have any guesses as to why the prevalence of dementia has significantly increased in the IDD community?
People are living longer.
People are living longer. Absolutely. People, including those with developmental disabilities, are living longer than before. And as I mentioned earlier, although dementia is not a normal part of aging, the number one risk factor for dementia is increasing age. So the combination of those two things has really driven that sharp increase, right?
Corey,
According to, yes?
we have a couple other answers in the chat. Jolene said aging and medication, and Yolanda said more resources.
Yes, absolutely. Those are absolutely true. We're able to diagnose better than we were even just 5 years ago. Our ability to diagnose dementia has significantly improved. The advances that have been made in the dementia research space over the last decade are far more than the 5 decades combined prior to it. So it's a really exciting time right now in Alzheimer's research. More education, absolutely, Kevin. Preservatives and additives in our food, yes, but that presumably would affect everybody, regardless of whether they have a developmental disability or not, right? Thinking back, adults with IDD, first of all, are 2 to 3 times more likely to develop dementia than anybody in the general population. So that's a significant number. An onset occurs an average of up to 20 years earlier. So, for example, the average lifespan of a person with Down syndrome in 1983 was 25 years old. Today, it's 61. And that is fantastic, phenomenal information for us to have. It's so hopeful to see that. However, it has presented this whole new area of concern because as that person is aging, and based on the fact that people with a developmental disability are at so much higher risk, really has created this whole new concern for us to be able to address. So the highest dementia risk in the developmental disability space is for people living with Down syndrome. So according to the National Down Syndrome Society, about 30% of people with Down syndrome who are in their 50s have Alzheimer's disease. About 50% of people with Down syndrome in their 60s have Alzheimer's disease. Anybody have any idea why that is? Any thoughts on that?
Go ahead, Renee.
Hereditary?
So yes, there's a genetic component to it. So there is an overabundance of a protein called APP on the extra chromosome 21 that causes plaques in the brain that we have now learned are a hallmark of Alzheimer's disease. Great job, Renee. So this is a significantly higher risk than for the general population. So prevalence of dementia in people with IDD without Down syndrome was found also to be higher at a younger age than in the general population, but still lower than for those with Down syndrome. So things like age, severity of a disability, duration of education, and other medical issues like hypertension, depression, stroke, and traumatic brain injury all can increase this risk. So I like this visual. It kind of shows us that cross section between IDD and dementia. These are not mutually exclusive things that can happen to a person, right? A person can have both of those things, but understanding the difference between them is really important. And I'm not going to read this whole slide to you. I'm sure you can read that for yourselves. But the big takeaway here and the big distinction is that IDD is a lifelong, non-progressive condition that begins early in life. Dementia is an acquired progressive decline in cognition that occurs later in life. But you'll see that there is an overlap. And please know that these shared symptoms, that is not an all-inclusive list. These are just some examples, and they won't apply necessarily to everybody. It will depend on that person's disability, that person's dementia, and that person as a person, right? So things like difficulties with memory, problems with communicating, challenges with daily activities, day to day, poor judgment or decision making, disorientation or confusion, and social withdrawal or changed behavior all can be symptoms of both. And so that kind of brings us to this quandary, right? Where there are some unique challenges in being able to diagnose dementia in a person who has a developmental disability. So the first issue is with detection, right? It is really important to recognize the signs and symptoms of dementia in a person with a developmental or intellectual disability and not dismiss them as part of the person's pre-existing disability, right? So the key is identifying and understanding that person's baseline, right? So baseline differences in executive function, communication, or behavior may obscure that decline, right? So having a medical professional or a professional in the dementia space who can help to parse out the difference is really important. A baseline provides the most reliable way to identify changes that may point to dementia. You can create a baseline informally by just noting things like basic self-care skills, communication, talents, skills, activities, hobbies, etc. throughout adulthood. And the Alzheimer's Association specifically recommends documenting a baseline of adult cognitive, behavioral, and functional abilities in the individual with Down syndrome by age 35 to support the early recognition of dementia-related changes. And I'm sure that would apply to many developmental disabilities, but they particularly, because people with Down syndrome are at a high risk, that helps to kind of put that maybe more at the top of the list. Traditional dementia screening tools are really, many of them not equipped to support being able to diagnose a person who is living with a developmental disability. There are some tools that have proven to be effective, and I will share those in links toward the end of our presentation today. Testing outcomes can also be affected by sensory sensitivities or anxiety. And how dementia presents itself is our second issue, right? So what we tend to find with people who are living with a developmental disability and may have a dementia diagnosis is increased distress with changes in routine, uncharacteristic withdrawal from preferred activities and social opportunities, decline in self-care or adaptability, new confusion in familiar environments, reduced ability to execute tasks that had been mastered previously, and significant behavioral changes compared to that person's baseline, right? So that presentation is so important in that understanding what that person's baseline is can help us to distinguish what might be new. It's important to remember that dementia is going to be an onset later in life, and it's going to be new changes that are different from what that person's norm is. Okay, so now we're going to move into more of the practical piece of our program today. So to start, I want you all to pretend that you have an opportunity. I say, hey, can you come and meet with this person who we're considering as a resident in our long-term care community, for example. And all you know is that this person has dementia. And you're expected to go in and sit down with that person, make them feel comfortable, get to know them. In a perfect world, what would be helpful to know about that person and about that person's dementia to make that interaction the most positive possible? What are some thoughts that y'all have? You can put them in the chat or you can unmute your mic. What are some important things that might be helpful to know about that person and about that person's dementia that could help make that interaction the most positive possible? What is their routine? Yes, Yolanda. Family history. Thank you, Kevin. Yes, very good. What else? Some of their symptoms, right? And that's going to maybe tie back to, do we know what type of dementia that person has? Because as we've learned, Alzheimer's disease, dementia with Lewy bodies, frontotemporal dementia, all of those can have very different symptoms. And even two people with the same type of dementia can have very different symptoms. History of things they enjoy. Yes. Sports, hobbies, child bringing up. Yep. Hobbies, what type of things they like to make a connection. Absolutely. So what are their likes? What are their dislikes? All of these things are really, really important because for example, we're probably not going to have the same conversation with a person who was just diagnosed in the early stage of dementia as we are maybe with somebody who's just entered the late stage of dementia, and kind of knowing in advance a little bit about who they are and what their habits have been, what their hobbies are, what their likes are. We would want that, right? And maybe most notably, what are their abilities? I do believe in our society that many of us associate dementia with a loss, a series of losses, right? And that's not altogether untrue. But we need to kind of flip the script and figure out what abilities are still there. What can that person still do? What do they still enjoy doing? And that's what we call person-centered, right? My dad played the bagpipes. He loved listening to the bagpipes. Maybe not everybody enjoys listening to the bagpipes, right? So the music that we would provide for my dad might not be music that the person sitting next to him would have enjoyed, right? But that's why it's important to really get to know who that person is, and their abilities, their interests, their likes, their dislikes, and then knowing their traumas and triggers, right? What could cause them to become upset? That family history that Kevin mentioned. Do we happen to know that a close family member of theirs has passed away? And maybe we want to make sure we're not necessarily asking about that person right away. So this is how we provide that person-centered approach. So a person living with dementia will have progressive issues in communication as the disease gradually diminishes their ability to communicate. And changes can be different based on the type of dementia, the person, any other disability that that person may have. And I'm going to put this on here. It's going to be a lot of words, but we'll walk through it. So frequent challenges, and this is not an exhaustive list. There are many more, but these are some common ones. Difficulty finding the right words, right? But if you're having difficulty finding a very common word that based on your baseline, you historically had not having had a hard time finding, that's going to be more of a concern, right? And that might cause that person to describe that item rather than actually naming the item because their brain is just not able to pull that word out. So I might say something like, that thing on your wrist that tells you what time it is, because the word watch is not something I can pull. This person may repeat questions or statements over and over again. Are they doing that on purpose? Of course not. If they remembered that they had asked that question, you had answered it, they probably wouldn't be asking again. That's the result of those brain changes that we talked about earlier. This person may lose train of thought more easily compared to their baseline, and also may not be able to get back on that train of thought or know that there's a train of thought to get back on. There may be more time needed to respond. They may have some challenges with managing their emotions, difficulty processing their environment, the who, what, when, where, and why of what's going on around them. Wandering can occur. Challenges organizing words logically to get messages across. Speaking less often because they're not quite sure what to say and they're taking time to be able to understand what's happening in their environment. And relying on gestures and cues more than words. So I want you to take a minute and think about yourself in the shoes of this person. Okay. You are at a dinner party and you're talking to a small group of people and you're telling a story, and then suddenly your mind just goes blank and you have no idea what you were talking about. You're not totally sure where you are or who you're talking to, and everybody's just staring at you, right? You ask somebody a question and they respond with, "Why are you asking me again? I just told you the answer 5 minutes ago. Stop asking." Or you're thirsty and your brain is not allowing you to put the words into an order that can relay that need to that person in front of you. How do you feel right now? How would that make you feel? Frustrated. Debbie, that's always my first answer. Yep, frustrated. Agitated? Embarrassed. Yeah, Renee. Yes. I mean, we don't want to feel that way, but yes, right? And so this is what we hear from people who are living with dementia, how they feel sometimes because of some of these symptoms that they're experiencing. And the core of it is fear. So often, when we are helping to care for a person who may be living with dementia, it's important for us to put ourselves in that person's shoes and understand what it might be like for that person experiencing those symptoms. Great job, y'all. So, although there is a lot to consider in order to effectively communicate with someone in varying stages of Alzheimer's disease or another form of dementia, there are generally 3 cornerstones that form the foundation of successful communication. Understanding the person responsible for that communication, being flexible to use different types of communication, and defining the reality that we're in. So let's break those down. So communication is a feedback loop, right? And a person who is cognitively healthy knows that all parties involved in that conversation share equal responsibility for ensuring understanding. A person living with dementia is exhibiting these symptoms as a result of the brain disease that is gradually impacting their ability to communicate. So you are the person, I am the person who can ensure that that communication between me and that person with dementia that I'm caring for, to ensure that effective communication and that that's working well. It's also important for us to remember that communication is way more than just words, right? It's not just our speaking, it's our ability to listen, our ability to be present, and our ability to connect with that person. Let's move on to different communication types. So as any type of dementia progresses, communication is nearly always significantly impacted, as I mentioned, particularly the use of words. So, and this may be compounded by a person's disability if language is already impacted. So a person living with dementia may struggle with using and interpreting language as we know it. So trying different ways of communicating can help. So let's talk about verbal or speaking communication. And I look at this and I always think, this is really how we should be speaking to anybody. I mean, I'm having conversations with anybody, right? We want to keep directions short, simple, and concrete, not abstract. Keeping it two-way. We don't want to talk at that person. We want to talk with that person. So it's important for us to be listening. Tone and inflection matter, right? I don't probably sound very warm and welcoming with that tone and inflection. And then the importance of making eye contact while we're making those speaking cues. And then nonverbal, non-speaking cues can be just as important. Facial expressions, body language, behavioral cues, and the use of senses, right? Like if I'm looking at you like this, I don't have to say a word. And that's probably going to evoke an icky feeling within you, right? Those are emotions that are baked into us from an early age. So it's important for us to be aware of what our tone, our facial expressions, and our body language are relaying to that person. So the third cornerstone is whose reality we're in. So let's say Constance and I are having a conversation. Constance is cognitively healthy. I am, let's say, in the moderate stage of Alzheimer's disease. And I say to Constance, Constance, did you hear the aliens landed yesterday? Now, Constance is reasonably sure that's not true. But what is a way that Constance maybe should respond to me in that moderate stage of Alzheimer's disease that I'm in? Or conversely, what's a way that maybe Constance shouldn't respond? Any thoughts on that? I say so. I'm not distressed by the aliens. I'm just letting her know the aliens landed. How might you respond to that if you were Constance? It doesn't have to be Constance who answers this question. What are your thoughts on that? Well, Constance did answer. Thank you, Constance. So should not say there is no such thing as aliens, right? Right. Tonda, don't deny. I have a degenerative brain disease. Right. And so, right. So Lakila says, where did they land? Right. I may respond that there are no aliens, but otherwise I need to be supportive. So if it's a situation where I'm not distressed and I say something that contradicts your reality, what is the harm in entering into my world and being with me? Right? And just going along with it. The person with dementia, their reality is the only reality. They have a degenerative brain disease that will not allow their brain to come into your reality. And trying to drag them into yours is likely going to just end in frustration for both of you. So, want to live in their world, meet them where they are, respond accordingly. When my son was 11, he spent a lot of time around people living with dementia, and he said it's kind of like being an actor in their play, right? The person with dementia is always right, even though we may know that maybe that's not right. But that's when you ask your question, how important is it? Like, why argue? There's no point in arguing. So y'all did a great job. Thank you for your contributions. Okay. So now that we've learned about dementia, communication challenges, cornerstones, let's talk about strategies to effectively communicate and problem solve. And I want to make a very special note here that often we hear the term challenging behaviors or bad behaviors. But it's important for us to understand that those are often an expression of someone living with dementia to communicate an unmet need. Most commonly, either pain or discomfort, but it can also be the result of fear, stress, anxiety, confusion, just trying to interpret their surroundings. And as those caring for that person, we need to be detectives to try to determine and alleviate that root cause. So let's talk about some day-to-day interactions and some strategies that may help. So we're going to start with how to greet a person with dementia. And keep in mind, you may already know this person, but this person's brain may not know you. So when we introduce ourselves to each other in the general public, we may shake each other's hand. It's been, kind of a tradition in our society. Now, not everybody likes to shake hands. I am a hugger, and I always check with people before I go in for that hug, because that can be really stressful for people who are uncomfortable with that. And that can be the same with a handshake sometimes. But oftentimes, if you extend your hand and that person extends their hand, that is a cue that there's a level of trust established between the two of you. If that person does not extend their hand, that's a cue that, okay, maybe I need to back off and give them some space, or understand that a different approach may be necessary. I also want you to think about visual field. Take a moment to just make binoculars with your hands around your eyes, right? And I want you to assume that every person you talk to, whether they have a disability, whether they've been diagnosed with dementia or not, assume that this is their visual field. Now, somebody who is aging and is living with dementia and may have had a lifelong disability that relates to their visual acuity, maybe I'm up here saying, okay, you need to eat your lunch. Okay, this person does not know that that I'm talking to them, right? Then I don't eat my lunch, and then they become frustrated, and then where does it end, right? But if I'm in front of you and I'm looking at you and engaging you, you're going to be more likely to respond to that. So we want to make eye contact, be at eye level, be aware of those facial expressions and tone, using their preferred name. We making up our own nicknames for people who have lived with the same name their whole life and now have dementia is probably not a fair situation to put them in and expect a response from that person. We also don't want to assume that they remember our name, and we definitely do not want to quiz them. Somebody with a cognitive impairment oftentimes has memory loss. Quizzing somebody with memory loss really just makes them uncomfortable and doesn't give us the information that we need to really be able to do anything with, right? And please do not approach or touch without warning. I'm sure that already sounds familiar to you. So alternative communication options, as we discussed, communication is more than just words. So being aware of alternative ways to communicate a message is really important, and to try those, right? Oftentimes words that are lost, particularly in the early to moderate stage of dementia, tend to be nouns, people, places, things, right? So let's say I come in and I say, oh, I'm looking for the thing, and I look at Hattie and I say, can you help me find the thing? And, Hattie can say, maybe Hattie has enough context to understand maybe what I'm looking for. Maybe I've got food in front of me and there's no fork there. But if there's not a contextual cue and Hattie's just listing off a bunch of things, none of which are the things that I'm looking for, I'm probably just going to get frustrated. What could Hattie ask me to help determine what I might be looking for her help to find? Any thoughts on questions that Hattie could ask me as a person in the moderate stage of Alzheimer's disease again, when I'm looking for something and I need her help, but I can't think of the word, and it could be anything. She's trying to narrow that down. What could she maybe ask me? What do you do with the thing? Yes, Constance. Can you describe it? Can you show me? Can you point to it? Right? So maybe I say, yeah, it's that thing that makes my hair look pretty. Well, can you show me? Yes, that thing that makes my hair look pretty. What am I asking Hattie for? That thing that makes my hair look pretty. A brush, right? Did Hattie use the word brush? No. but she knew the questions to ask me to try to drill down to get to the bottom of what I might be looking for. Signage can be very effective. So you look at this sign, we probably all recognize that as a stop sign. It doesn't have the word stop on it. So how do we know it's a stop sign? Right? It's the design, the color, the shape, right? There's enough of a visual cue from that. Now this says stop, but the color doesn't indicate stop, right? So making sure that we're using all of the potential cues with our signage is really important. Words, shapes, colors, designs, all of which are going to be more familiar to people. Now, I'm reasonably sure nobody on this call would make a green stop sign, but you understand my point, hopefully. So just having visuals, even without words, can be tremendously helpful to help direct people and help keep them as independent as possible. When asking a question of someone with dementia, it can be helpful to keep those questions yes, no, or to give simple choices. So if I were to, invite you over to my house and I said, what would you like to drink? And you're like, well, I don't know. What do you have? And I'm like, oh, Coke, Diet Coke, Sprite, apple juice, cranberry juice, orange juice, coffee, tea, sweet tea, unsweet tea. And you're like, oh my gosh, I'll just have water, right? Like that's overwhelming. So to give too many choices can be overwhelming for that person, but to still give them choices so that they can make those decisions for themselves is really important. Maybe you happen to know that I love coffee with breakfast and maybe all day. And so you come to me in the morning and you say, Tori, would you like a cup of coffee with breakfast? And I say, yes, please. I'm making that decision for myself. You're not just shoving a cup of coffee in front of me. Right? Or maybe you say, Tori, would you like a cup of coffee or a glass of juice? Right? Simple choices. Now, open-ended questions do have their place and can be used strategically, right? Maybe you happen to know that I grew up on a farm, and you can use that as a way to reminisce with me or to redirect the conversation. So you might say, Tori, what was it like growing up on a farm? Right? And that's going to tap into my long-term memory, which tends to stay intact longer than short-term memory, particularly with Alzheimer's disease. So now we're going to talk about the VRR approach. So in the earlier example, when I told Constance that the aliens landed, I was not distressed by that. But what if I am distressed by something that I'm saying that is not true? Right? So the VRR approach stands for validate, redirect, and reassure. And this is just an empathetic approach to help comfort and reassure your care recipient who may be anxious or stressed. So the first step is to validate their concern. Now, validating is acknowledging, but may not necessarily mean you agree, right? To validate somebody's feelings doesn't necessarily mean that you agree with them. Next is to redirect, which is simply shifting the focus away from a situation that causes fear or anxiety to one that is more calm or pleasant. And then simple reassurance, providing comfort and a feeling of safety. So a common example that I get asked about a lot from people is, maybe I'm that person in the moderate stage of Alzheimer's disease, and I say to all of you, oh, I'm looking for my mom. Can you help me find my mom? I really miss my mom. I need my mom. And please help me find my mom. And I'm clearly distressed. But you happen to know that my mom died 8 years ago. Now you can tell me that. Why might that not be the best approach to remind me that my mom died? Why might that not be the best approach? If I'm asking for my mom, but you know that she's no longer living. Could trigger emotions, trauma, right? More anger, agitation, fear, sadness, grief, right? Probably everybody on this call has lost somebody close to them at some point. Imagine hearing that news over and over again, right? If I'm asking for my mom, I clearly do not remember that she is no longer living, right? But then how do you handle that, right? So maybe you could approach that with something like, well, your mom's not here right now. Technically true. It sounds like you're really missing her. Validation. Well, I'll sit with you until she gets back. Reassurance. I've never met your mom. Can you tell me about her? Or what would you like to do with your mom when she gets here? And chances are, again, moderate stage of Alzheimer's disease, I'm not going to remember that I was asking for my mom. So that is the VRR approach, where we validate that person's emotions. We don't argue with them. We go into their reality and then try to redirect the conversation and give that person reassurance. And that brings us to the concept of therapeutic fibbing. So this can sometimes be difficult, particularly for family caregivers, because we are raised to be honest, right? And to be trustworthy, and lying to somebody is just not something we were raised to do. But what's important with therapeutic fibbing in the dementia space is that you're not lying to the person, you are lying to their disease. And you're not lying for the purpose of deception, you're lying for the purpose of compassion, right? So a good example is a personal one of mine. My dad traveled a lot in his job. And when he was going through his Alzheimer's journey, in his mind, he was always getting ready to catch a flight somewhere. And this is before I knew anything about Alzheimer's disease. I was like falling on my face, making mistakes left and right. And I would say to him, so I would show up, he would have a bag packed a lot of the time. And he would say, when is our flight? Thinking I was being helpful, I would say, oh, there's no flight, Dad. Nope, there's no flight. We're staying here. Let's go unpack your bag. Well, how do you think that ended? Not well. Like, he would just become more agitated. I wasn't listening to him. I didn't understand that there was a flight to catch. And I was not a safe person for him to help him in that situation. So I eventually learned that that was not the best way to respond. And I would respond with something like, I just checked at the front desk and they said we're here for one more night. We're going to catch our flight tomorrow. So go ahead and keep your bag packed. And why don't we go get a cup of coffee? And y'all, literally every single time I did that, that was reassuring for him. He was satisfied with that answer. It doesn't mean he didn't ask me 25 more times, but I always had a satisfactory answer for him, and it gave him that peace and comfort. So those comfort phrases, let's not overthink it, right? Let's not try to make it more complicated than it has to be, right? You're safe. I'll protect you. How can I help you? And can you help me? That feeling of contributing, of doing things that are meaningful, that have purpose, can be a great redirection for somebody. So some things to keep in mind, some practical considerations are to preserve familiar routines and environments. Use predictable schedules. Use those visual supports. Transitions and disruptions to that person's typical routine should be minimized to the greatest degree possible. We have to adapt our communication to any kind of sensory or cognitive needs, and we want to focus on that person's abilities, not on their disabilities. So just ensuring independence and engagement, offering safe choices, understanding abilities and how to support those. Let them lead and we follow. Encourage their purpose and meaning, and only take over as a last resort. So big picture takeaways is we want to focus on the person, not the task. Listen to that person and validate their emotions. Talk with that person, not at that person. Do things with that person, not for that person. Follow their emotion to determine their need, and all of these things will go a long way to establish trust. We are putting that person at the center of our communication and care. The benefits, clearly more trusting relationship, prevention versus reaction to many difficult situations, and that lowers stress levels, providing an improved quality of care and an improved quality of life, both for that person as the care recipient and the person providing the care. Studies show that nearly 90% of people with dementia will express their emotions through behaviors that may be considered challenging. There was a Harvard Health Journal study that showed that non-drug interventions, like the ones that we've talked about today, appeared to be not equally as, but more effective than medications in reducing agitation and aggression in people living with dementia. Activities that we can focus on. I can't stress how important music is. Now, not everybody enjoys music, and certain types of music may be more enjoyable for somebody than other types of music. But music, the part of the brain that processes music, is one of the last to go. And if you think about it, you're driving along and you hear a song on the radio and you're like, oh, I remember dancing with so and so to this at prom, right? I can't remember my password that I created this morning, but I remember that, right? And that song is what triggered that memory. So music, there's a wonderful program called Alive Inside, and it speaks to the impact that music has on people, particularly in the later stages of dementia. Of course, sensory activities. I'm sure this is not anything new to you, but sensory gardening, modeling clay, simple sorting like color sorting, being out in nature, and then having simple normalization tasks with purpose, things like folding laundry or everyday tasks that person is still able to do. And I'm going to finish just with some information about our Dementia Care Specialist program. We started this program 3 years ago, and we now have 10 dementia care specialists around the state. I hope you will reach out. I will send some links to information to Carrie to send out to all of you if she's willing to do that. And then we also have dementia education programs and our South Carolina Department on Aging Dementia Toolkit, which is a 40-plus page reference guide with a number of resources in it to help people in South Carolina navigate a suspicion or a diagnosis of dementia. And I think we're at 1 minute left. If there are any questions that I can answer, I am happy to do that at this time. I will look at the chat. And Carrie, I don't know if there were any questions prior to this in the chat. Got it. There's been a lot in the chat, so I just wanted to make sure I didn't miss anything. You're welcome to unmute, or I'm happy to take your question in the chat. And I'm going to go ahead and put my contact information up here. I am the program manager for our Dementia Care Specialist program. I'm also the dedicated Dementia Care Specialist for the Midlands region, but we have a specialist that can help support families all over the state.